After the long-awaited pregnancy, baby's finally here. So the purpose of this lecture is to basically just go over immediate care of the newborn in those first couple hours of life, and particularly watching their transition. So newborn assessment at birth. As the baby emerges, we're automatically looking for a few things. What does baby's tone look like? What is their skin color? Are they breathing or crying? You can use their umbilical cord to check for their heart rate, ideally feeling close to baby's body, so just above the stump there. And then if findings are normal, baby can just go right up to mom, provide warmth, dry the newborn off, clear the airway as needed, and essentially just help facilitate bonding, creating that sacred, safe space for that family to get to know their newborn. And then if findings are abnormal, then that's when you would kick in and start NRP. So let's just take a look at this baby. Pretty easy assessment right from the get-go there. Can't really tell color, though that fresh. I don't even think I really care if we're completely blue, right? But we've got some good tone there, and you take a look at baby's face, we've got a good grimace, and probably that's a huge whale. So baby looks vigorous is how I would describe this baby right from the get-go. So APGAR scores. It's important to say just right up front that this is never the basis for resuscitation decisions. You're using your NRP decision-making tree to decide whether or not you need to give this baby extra assistance for transitioning. But it is a nice snapshot. It gives us just a basic overview, especially in hindsight looking back. How is this baby transitioning at 1 minute? How is this baby transitioning at 5 minutes? And then if 5 minutes isn't great, we'll do it again at 10 minutes. So it gives us a snapshot, and just how it doesn't help guide decision making around resuscitation, it also isn't a predictor for long-term prognosis. You can have a baby who comes out really not looking great, jump start, we're back on track, and you'd never know in the long term. So when we're assessing for APGAR scores, A is for appearance or color, P is our heart rate, pulse, G is grimace, A is for activity, looking at our muscle tone, and then R is for respiration or respiratory effort. So to look at that again here, so for color, if we've got pink hands, pink feet, that would be a 1. It's not uncommon to lose points for color. Actually, most of the insurance companies that I'm working with right now, even for 5 minutes, if we were to say a baby's APGARs were 9 and 10, they would now I'm forgetting if it's insurance company or the birth certificate. Basically, they're giving us flack saying that no baby would be a 10, and that all babies are going to have at least the acrocyanosis, which I don't think is always true, but it's pretty, we're going to come out completely blue, and it's pretty common to still have at least blue hands. So don't ever feel bad about taking color off for that, or points off for that. Heart rate, if we're over 100, we get all our points. Reflex irritability, if we're crying or coughing or pushing away, we've got good reflexes there, then we get all our points there. Muscle tone, if you see active motion, really well flexed, babies moving, making deliberate movements, we're good on muscle tone. And then respiratory effort goes from 0 to a vigorous cry. And if you've just got a really calm baby, say it's a water birth, and you've got your stethoscope there and baby's clearly breathing well in all our lung fields, I don't tend to take off for that even without a vigorous cry. So basically we're doing a 10-minute APGAR if our 5-minute APGAR is less than 7. And anytime you've got a lower APGAR, your note should really include a narrative story of what happened. So, baby came out, this was our situation, we tried this, this didn't work, we tried this, so going through basically your NRP story. And then also alluding to why you think it happened, prematurity, meconium, so paint the full picture. APGAR scoring, greater than 7 at 5 minutes is rarely associated with perinatal asphyxia, and even less than 7 at 5 minutes only slightly increases the risk for poor neurological outcomes for example, cerebral palsy. So cord blood gases. Basically, in terms of really having a good sense and an objective assessment of their metabolic condition at birth, cord blood gases are going to trump APGARs every time. So it's the provider who ultimately will determine whether or not they should be collected, and they would be the ones collecting it. So you as the provider would collect it if you felt like it was important. So it determines the level of asphyxia for baby, and it's usually taken as arterial, so if it was venous and arterial, that would be ideal. So arterial, that'd be coming right from the baby, so that would give us a sense of fetal function, whereas if it was venous, then that would be coming from the placenta, so that would give us a clue as to the placental function as well. So you think about if you do have a baby who's not coming out great, might it be due to placental functioning? So that can be insightful in helping paint that full picture. So if you decide you're going to collect cord blood gases, you would just double clamp a big section of the cord and send that whole section of cord with blood in it to the lab. And it's good for about 60 minutes. So usually you want to think about cutting off or clamping off about a 5 to 10 inch section of the cord. One way to think about it in your decision making postpartum would be that if the first APGAR is less than 7, consider going ahead and collecting it right then. And then if your second APGAR is still less than 7, then send it to the lab. Regardless of the APGAR though, there's a few conditions where you still might want to consider sending cord blood gases. So ACOG put out a bulletin in 2007 with additional situations where you might want to consider doing it. So if you had abnormal fetal heart rate tracings in labor, especially if they ended up leading to a cesarean delivery, that would be worth considering. Low 5-minute APGAR scores, like we've already talked about, severe IUGR, maternal thyroid disease, interpartum fever like choreo, and then multifetal gestation. So reasons to consider sending cord blood gases. So acid-base imbalances, let's think about, before we look at how we would interpret cord blood gases, let's think about what that imbalance would look like. So it's a progression. Hypoxia would be initially what we would see, and we can see that babies initially would respond with compensating in a way that's essentially leading to respiratory acidosis. So we know that respiratory acidosis, when we're talking respiratory, that's CO2 levels, right? So CO2 is acidic, so if we're not doing a great job breathing, then our CO2 builds up, and then that's when we would say we have respiratory acidosis. And then if that's happening, we start being a little bit tachycardic, and we see some brain shunting so that the brain is able to get enough oxygen, and ultimately then we have metabolic acidosis from lactic acid with anaerobic metabolism. And when we're looking at anything that's metabolic, that's thinking about the base component with bicarbonate. So if bicarbonate is high, then we have more of a basic situation, whereas in this case, we have lower bicarbonate levels, which would lead to metabolic acidosis. Now we can think about hypoxia as being acute or chronic. So acute would be typically directly affecting the fetus's blood flow in labor. So thinking about cord compression, hypotension, hypovolemia, maybe like in the example of an abruption, nuchal cords, especially if you had 2 or 3 or 4. Nuchal cords are fairly common, I want to say 20–25%, but if you've got a few wrapped around, or if it's just a particularly gnarly one, sometimes that can affect babies in utero, and then initially in their transition, or maybe we incidentally found that the cord had a true knot in it. So those sorts of things can attribute to an acute hypoxic event, whereas chronic hypoxia would be typically placental insufficiency. So maybe smoking, renal failure, maternal hypertension, congenital abnormalities, those sorts of things. can lead to chronic hypoxia. So you can see that the source of the hypoxia could be baby, but it could also be mom or be the placenta. So acute hypoxia is usually not associated with poor outcomes long term, whereas chronic hypoxia has a higher incidence of long-term neurological consequences. Okay, so we start with respiratory acidosis, and then it progresses from there. So respiratory acidosis could be variable D cells, and then so that could be cord compression, and then that's our first compensatory mechanism. And since it's respiratory, we know that we're retaining our CO2. So CO2 is an acid, and so we've got increased CO2 retention, and then a lower pH, which all of these would be a low pH since it's acidosis, right? So then mixed acidosis, we have potentially variable D cells or prolonged D cells, and then increased CO2 retention and a lower pH like we had before, but then it would also have the decreased O2 and the increased base deficit that you'd see with metabolic acidosis. So then metabolic acidosis, more likely with late D cells, that's our final compensation, decreased O2, lower pH, and increased base deficit. And that seems just a little bit backwards when you're first thinking about it. So the more base you have, the less likely you're going to be acidic. But we're looking at an increased base deficit. So kind of a double negative in that sense. So increased base deficit will mean it's more likely to be acidic. So interpretation of cord blood gases then. You're looking at the pH, the PCO2, the O2, and the base deficit. So here's your normal ranges, and then with respiratory acidosis, as with all of these, we see a low pH, and then we see that our CO2 is up, but the rest of these are normal. And then the metabolic acidemia would have the CO2 normal, and then the rest of it's going to be off, right? So our O2 is low, and our base deficit is high. And then with mixed, we see that everything's off. So it's a combination of both. So ACOG in their 2007 bulletin also had criteria to define an acute intrapartum hypoxic event that would be sufficient enough to cause cerebral palsy. So all four of these criteria would need to be met. Evidence of metabolic acidosis in the cord blood, arterial blood, and you can see the numbers there. Early onset of severe or moderate neonatal encephalopathy for babies born at 34 or more weeks gestation, so ruling out anything else that could cause it earlier. And then the CP is spastic quadriplegic or dyskinetic type. And then finally, there's nothing else to explain it, such as trauma, coagulation disorders, infectious conditions, or genetic disorders. Okay, so let's transition here we're kind of putting behind us if things are wrong, what does that initial assessment look like, and what might we consider doing? And then let's just take a look at what our role is in general with newborn transition, which usually is not eventful, I guess is how I'll put that. So first few hours, infant is adapting to extrauterine life. You know that really takes a few days, but those first few hours, so much change is happening, particularly with their circulation. And they're breathing for the first time, so really, really, really big physiologic changes, which we talked about in reproductive physiology, so that is by no means new. But it's a big change. So really, one of our main roles is just to be watching and overseeing that change and recognizing what's normal. We're the experts of normal, right? And then being able to see and find who isn't transitioning very well so that they can get additional help if needed. So it's composed of 3 stages, which is the next slide. I'm sorry if you're hearing a lot of background noise. My 2 cats are chasing each other back and forth across my wood floors in my living room, so it's kind of distracting me, and I'm hoping it's not distracting you too. Okay, where was I? So midwifery management. Basically, our role is to help support bonding, creating that space for families to bond with their newborn, right? So creating that sacred space and really being a guardian and a protector of that space. Assisting with early breastfeeding, especially in that first hour, that's when we're wanting to get in. And then being able to recognize factors affecting normal transition. So that includes being able to pick out who's not transitioning well, but it's also just being mindful of things like making sure baby's able to stay warm so they don't have to deal with cold stress, those sorts of things. So recognizing factors that will help facilitate a normal transition and keep them on the straight path. And you can do so much assessment, just looking at this picture, with just your eyes. So you can tell that this baby's pink, looks pretty darn well flexed on their own, even though you've got mom holding him. Yeah, super pink. So already looking good. No reason to interfere, even just from this one little snapshot that we see. So 3 stages. First stage is the first 30 minutes, and we think of that as our first period of reactivity. So you might notice an increased heart rate here, as well as a respiratory rate. I kind of think of that as a transitional tachypnea. Increased tone and motor activity, presence of rails, grunting, flaring, retractions. So we're expecting baby to be born with lungs full of fluid, and we're expecting that they might sound kind of grunty, and they're working all that fluid up. So that's anticipated, that's not abnormal. And they've got mom's adrenaline, so that's part of why we're more reactive at this point too. So they have acute smelling and hearing, eyes wide open, just taking in the world. So really, really, really exciting time to just be able to be present and to witness. And then, and really this is the most ideal time for bonding too, while baby is all wide-eyed and bushy-tailed. And while baby is hearing sounds for the first time, that it could be the voices this baby's used to hearing. So really wanting to promote bonding for that period. And then in the second stage, 30 minutes to 2 hours, baby kind of gets tired and needs a nap from birth, is how I think about it. So we're a little bit sleepy, decreased motor activity. We're still nice and pink, and then you start seeing that fast and shallow synchronous breathing. Heart rate might even dip just a little bit. All of that's normal. Yeah, and their tone will look a little bit more relaxed, so they're just a little bit conked out at this point. And then somewhere between the 2 and 8 hour mark, our second period of reactivity, or around the 2 to 8 hour mark, I should say, we have a second period of reactivity where baby becomes more responsive again. And you'll start seeing brief periods of rapid respirations. And we know that newborns have pretty crazy breathing patterns, as far as being super fast and then slow and then maybe not breathing for 10 seconds and then back at it again. So we're always anticipating some of that with newborns, but just recognizing it and calling it normal is important. So it's nice to be able to stay with mom for that first hour and to be able to keep that extra eye on baby. Obviously that'll look a little bit different from practice setting to practice setting. But yeah, so that's the basic stages for transition to life. And then of course we're wanting to be able to get breastfeeding going within that first hour. So somewhere between, I think of it more as 30 minutes to an hour and a half. These are the formalized stages, but somewhere between 30 minutes and an hour and a half, baby will get pretty sleepy. So if you can get that first breastfeeding session in while baby's still fairly awake, it makes for an easier session. And then if baby's got a full stomach, then you feel better about getting a good breastfeeding session in, and then when you see baby conk out, you say to mom, why don't you go ahead and conk out now too until baby wakes up again. So that works out nicely. So for my last slide here, I just wanted to say what a privilege it is for us to be able to walk this journey with families. We've been journeying with women all through pregnancy, and while obviously we've been caring for this newborn all along, we've been measuring their growth, we've been listening to their heart rates, Most of our care really focuses on the mom, right? But they are such little miracles, and we really have been walking this journey since they were really, really, really tiny. And so to do our part in educating moms in their nutrition in pregnancy and to help keep this baby in and decrease preterm labor, I mean, we've done a small part in helping get this baby to this place. And they are such little miracles doing amazing work in transitioning. You just think about the difference in placental blood flow and circulation to extrauterine life and how different that is. They look so small and fragile, and yet they are so strong. So to have done our part in pregnancy and then to have done our part in providing a quiet, gentle entrance for this new life, we can't emphasize enough what a privilege that is. And again, just that we can assess so much with just our eyes here. We've got great grimace on this baby, pretty decent color. Look at that flexion. So this baby's doing great. And so if we can just provide space for bonding, sacred bonding for families, just to hold that space for them, to let this initial greeting of their newborn be unique and special and gentle. That's really what it means to be a midwife. And you can slip in a little stethoscope and get even more information as you need to. So keeping it gentle and keeping it sweet. All right, we're off. Newborn care has begun.